as you wish. This will go on YouTube live
Yes, ma'am. It's
or
already.
on your Facebook. How it go?
Oh, it goes on YouTube, ma'am. Actually, there is a we have a
Okay.
page Shield Connect in YouTube
Huh.
as well.
Acha, this will
So
go on. Okay,
yeah, it will
okay,
go live.
okay, 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 okay. After you want to start, you can start. No issues.
Yes, ma'am. So we'll start, ma'am.
Yes, yes, yes. Sure, sure.
Yeah. Okay, ma'am. Good evening, doctors. This is Dr. Someshwar from Shield Healthcare. I welcome you on behalf of Shield. Thank you very much for joining today's webinar. I request all the participants to post their questions in the comment box so that we will address at the end of the webinar. And good evening, Dr. Ritu S. Santwani, ma'am. Thank
Yeah.
you for joining today's webinar. Actually, it's an honor to introduce you, ma'am. You're very kind-hearted and always you support Shield for any guest lecture, I mean, any webinar. So actually, madam doesn't need any introduction.
Thank
Uh,
you.
Dr. Ritu S. Santwani, she is a obstetrician and cosmetic gynecologist and IVF specialist, honorary professor in Obs and Gynecology, Williams Medical College, Gujarat. She is currently, working at Shamwell Women Clinic. And coming to academics, she completed medicine from GSM Medical College, Kanpur, and MD in Obs and Gynecology, FACOG, ART course for clinicians from NUHS Singapore, postgraduate diploma in clinical cosmetology, medical cosmetology, RCOG Associate London, reproductive genetics, Foxy Justosis certified hypertensive disease of pregnancy, and Indian Academy of Obs and Gynecology honorary fellow from improvement of women's health. And coming to the career highlights, free health checkup camps for the underprivileged patient across Maharashtra, and crore participants in several social activities to uplift the backwardness to remote areas of India, along with Lions and Rotary clubs. and renowned speaker in on infertility, contraception, treatment, and other topics. Academic contributions by organizing many workshops, training programs, travel seminars, and conference across India. Coming to the key honorary participants,
Dr. Someshwar, I think this much is enough. Thank you so much. Thank you. Thank you. Thank you. Thank you so much.
yes,
Yes,
she
you can.
actually she participated in various international and national as well as coming to the publications as well. So with this, we welcome you, ma'am.
Yeah,
Before
yeah.
moving for the webinar, we have Shield Connect web page launch,
Uh,
ma'am.
okay, great.
Yeah. So I request KVK to please share the screen of Shield Connect. So this is a Shield Connect web page where we
Okay,
have created individual pages for the doctors with their consent. You can see today's speakers web page where we
okay,
have uploaded their past webinars as well as upcoming webinars.
okay,
Yeah, and like this we have created for most of the doctors, and as well as we have blogs
okay,
written by most of the doctors.
okay. That's good.
Yeah, and also we have webinars. I mean, you can see the past and upcoming webinars page,
Hmm.
as well as we have created a PCOS page, uh, PCOS awareness page in a regional languages
Okay,
for the patient awareness.
okay,
In all the regional language it is available, and yeah. So, and also we have our leaders page where the doctors who are the key KOLs who are supporting scientifically, giving the scientific information through webinars, blogs. So we have so many key opinion leaders who are supporting this page.
okay.
So Shield not only going, I mean, with the scientific innovation, uh, we're transforming the health of the patient care with one place of a digital platform. Yeah, with this, thank you, ma'am, for giving us the time. And I welcome you on today's topic where the challenges of endometriosis and infertility. This is a common condition where women at the reproductive age, and also it doesn't only cause pain but also reduce the fertility. And with the advanced stage of endometrium, may have a lower success rate of IVF. So with this, I give you all the uh,
Yeah, yeah,
control to you, ma'am. Yeah,
yeah, yeah.
over to you, ma'am.
Thank you. Thank you. Thank you so much, Dr. Someshwar. And special thanks to Dr. Prachi, Dr. Someshwar, and Mr. Balaji in Shield Healthcare. They are always ready for any academic activities. So I think knowledge sharing is the best thing. So I always believe in this motto. So with this motto, I'm doing lot of webinars. So thank you once again for Shield for arranging this. So now without delaying, I have started sharing the screen. Yeah, just a second. Yeah. I will make it presentation. Yeah. Yeah. I think slides are visible, Dr. Someshwar,
Yes, ma'am,
Mm,
we
Sajita.
can see this.
Yeah,
yes,
yeah,
चालेल.
yeah.
इंटरनेट आहे ह्याच्याकडे वायफाय
Slide is not moving.
त्या चिवड्याचा एक घास दे फक्त
Yeah.
चिवड्याचा एक घासच दे फक्त.
Yeah. So, good evening, everyone, and thank you all of the friends who have joined. So, the topic which I am going to discuss is the challenges of endometriosis and infertility. As all we know, before I start my talk for the endometriosis and infertility, this is a very, very common quote by Sir Winston Churchill is the endometriosis is an enigma wrapped in a riddle surrounded by the mystery. I hope all of you agree on this with me. Mm. And there is one also quote by an Albert Einstein who wrote, "The most beautiful thing we can expertise is the mysterious. It is the source of all true art and science. He to whom this emotion is a stranger is as good as dead. So, as we all know regarding this endometriosis, endometriosis is a chronic estrogen dependent inflammatory painful disorder in which the endometrial tissue grows outside the uterus. Most commonly involved sites are ovaries, fallopian tubes, and the tissue lining the pelvis, as well as the bladder, bowel, vagina, or rectum. This endometrial tissue thickens and bleeds just as the normal endometrium does during the menstrual cycle. So, we can see by this diagram the different sites of the endometriotic patches. So, what does the guidelines and status says regarding the prevalence? So, there is 6 to 10% of the women in the reproductive age group. 4 out of 1,000 women are hospitalized. Prevalence is 20 to 50% in the infertile women. As I'm an infertility specialist, so many patients of endometriosis are coming for the infertility treatment. 71 to 87% in women with chronic pelvic pain. 25 million suffer in India. It's a quite a big number. So, yeah. So now with what symptoms the patient is presenting? Symptoms like chronic pelvic pain, dysmenorrhea, dyspareunia, infertility. Few patients with unexplained infertility but no symptoms. Prevalence of endometriosis in subfertile women, 20 to 40%. Causes of subfertility are reported as reason may be due to inflammatory factors or additions with endometriomas. Now, as the type we know, either the pelvic or extrapelvic endometriosis. In the pelvic, the most common sites are the tubes and ovaries, in the uterus, peritoneum, uterovesical fold, posterior cul-de-sac, and pelvic side wall. While in the extrapelvic sites, the gynecological sites, vulva, vagina, cervix, and non-gynecological bowel, lungs and pleural cavity, skin, lymph glands, and brain have reported. There are several theories among the etiology: ectopic transplantation of endometrial tissue, coelomic metaplasia, the induction therapy. No single theory can account for the location of endometriosis. Yeah. So there is one theory by the Sampson, which that the menstrual regurgitation and implantation, which supports the metastatic theory that the retrograde menstruation endometrial fragments are transported to peritoneal cavity through tubes, viable cells implant and grow, and young girls with obstructive anomalies of the genital tract often develop endometriosis. In the coelomic metaplasia theory, this theory supports the original coelomic membrane transforms into the endometrial tissue, explains the endometriosis in ectopic sites, while the lymphatic and vascular metastasis theory, according to this theory, the lymphatic and hematogenous spread of endometrial cells, extensive communication of lymphatics between the uterus, tubes, ovaries, pelvic and vaginal lymph nodes, kidney and umbilicus. While in the genetic factors, interesting studies have been reported, and the status suggests the risk is 7 times more in the first degree relatives of the endometriosis. Now, coming to the theories of pathogenesis, as we know, the endometriosis is associated with subclinical peritoneal inflammation, which is marked by increased peritoneal fluid volume, increased peritoneal fluid WBC concentration, inflammatory cytokines, growth factors, and angiogenesis promoting substances. Involvement in the immune system in pathogenesis, as we can see, TNF alpha and interleukin 10 are elevated in endometriosis. Women with endometriosis have higher levels of interleukin beta, IFN gamma, and interleukin 4 and shift towards the inflammatory cytokines. We can see by this diagram also. So there are different sides of the endometriosis. We can see via this laparoscopically, the diagram is clearly showing. Yeah. Now coming the pathophysiology. Among the pathophysiology, the estrogen through the beta receptors increases the levels of macrocyte inhibiting factor, which increases the levels of PGE2. We can see estrogen causes the alpha and beta receptors in tumor necrosis factor, which increases the MIF and PGE2 and causes the endometriosis. PGE2 is the master pathogen in the pathogenesis of endometriosis. So, as we know, this macrophage migration inhibiting factor is also plays an important role. That how this macrophage migration inhibiting factor causes the increase of TNF alpha and PGE2 and causing the endometriosis. Mm. So, among the genetics, as we know, the studies have suggested the risk is 7 times greater as it is a first degree relative. Multifactorial inheritance is postulated, monozygotic twins. And there is one more study has been published by Oxford Endometriosis Gene Study working on the genetic basis. Now, the clinical presentations are different. The triad of dysmenorrhea, dyspareunia, or deep-seated pelvic pain, and it is the commence before the onset of menses and continue throughout the menstrual period, also cyclical in nature. Deep dyspareunia due to stretching of involved tissue during the intercourse, fixed retroverted uterus or involvement of uterosacral and rectovaginal symptom, dysuria, dysgeusia in extragenital endometriosis. Other the abnormal bleeding pattern like premenstrual spotting, polymenorrhea, and menometrorrhagia. While in the infertility present in the majority of the women with endometriosis, advanced disease, adhesions, and fixity results in structural damage to tubes and ovaries, impairs tubo-ovarian mobility, ovarian problems like anovulation, luteinized unruptured follicle, oocyte maturation defects, tubal problem, altered tubal motility or ovum pickup, peritoneal factors like intraperitoneal inflammation, sperm problems like phagocytosis by macrophages, inactivation by antibodies, and in the endometrium, the luteal phase defect and the implantation defects are being reported. So, as we know, the classification by the American Society of Reproductive Medicine, stage 1, 2, 3, 4, or minimal, mild, moderate, severe, according to the number of the sites involved, minimal 1 to 5, mild 6 to 15, moderate 16 to 40, and in the severe more than 40 has been reported. So, either the ultrasound or MRI. So, but these neither can diagnose the small peritoneal implants or adhesions. The TVS is highly accurate. Hemorrhagic cysts account for significantly false positive. That is very commonly in this. And in the TVS, the common findings are the retroverted uterus with obliteration of cul-de-sacs and bilateral complex adnexal mass. It helps to differentiate endometrial cysts from other complex cysts like dermoids. While in endometriosis, the typical ground glass appearance is very important. While in the dermoid, the posterior acoustic shadowing due to presence of bone and teeth in the cyst and the presence of mural nodule and the pins and needle. So laparoscopy is considered to be a gold standard in which the entire pelvis can be examined for the detection and biopsy of lesions, staging, and concomitant laparoscopic surgical treatment can be done via that. As we know, the classical signs are the chocolate cyst or the powder burn gunmetal appearance. Yeah. Hmm. So now, what according to ISHRE guidelines, the grading is into the A, B, C, and D. We will discuss this one by one. GPP will denote wherever use is for the good practice point, as mentioned by the ISHRE guidelines also. So, based on this guidelines, considering the diagnosis of endometriosis, the presence of symptoms, dysmenorrhea, non-cyclical pelvic pain, deep dyspareunia, infertility, and fatigue. While the women of reproductive age with non-gynecological cyclical symptoms, dysgeusia, dysuria, hematuria, and rectal bleeding and shoulder pain has been reported. While on the examination, as we know, the vaginal examination we can't do in the adolescents. So either the pelvis or palpitation of abdomen and rectal examination can be done, which is helpful in the diagnosis of the deep endometriosis, is painful induration or nodules in the of the rectovaginal wall can be found. So, in this, as we have just discussed, the TBS or MRI or the peritoneal endometriotic lesions are difficult to diagnose. ISHRE guidelines suggest a laparoscopy and histological evaluation, which is golden standard. So, non-invasive biomarker CA125 has been also been reported. but though it can't give in every time the correct information, because CA125 is raised in so many other conditions also. So challenges in the diagnosis, the point have to be specified: dysmenorrhea, non-cyclical pelvic pain, deep dyspareunia, infertility and fatigue, and non-gynecological like dysgeusia, dysuria, hematuria, and rectal bleeding, shoulder pain. Laparoscopy for diagnosis, confirming a positive laparoscopy by histology, uh, and lack of evidence if positive laparoscopy without histology proves the presence of disease. Histological examination of ovarian endometrioma and or deep infiltrating disease and malignancy has been reported. So, in ovarian endometrioma, as in the premenopausal women, the most important pictures on the ultrasound: ground glass appearance, no papillary structure. And while for the rectovaginal, the 3D ultrasound is not useful, we can see in this diagram the clear cut ground glass appearance in the endometriotic cyst. Actually, topic is such a vast, endometriosis to cover in one lecture of half an hour is very, very difficult. So MRI, no use of MRI to diagnose the peritoneal endometriosis, not the biomarkers, assessing of the ureter, bladder, bowel by the additional imaging. You can see here, as it is clearly pointed out, the endometriotic lesions. Yeah. Mm. Now, there is this I have got from the ASRM staging with the poor correlation with the pregnancy rate. In this, now coming the very, very important entity which is very much focused is endometriotic fertility index, for the based on the functional anatomy and the assessment of the tubes, fimbriae and ovary. EFI is assessed as 0 to 10. 0 is the poorest and 10 is the best prognosis. So this has been supported by the PubMed journal also. Endometriosis fertility index, the new validated endometriosis staging system, supported by BJOG also, which also suggests that endometriosis fertility index for predicting the non-assisted reproductive technology pregnancy after the endometriosis surgery, and a systematic review and meta-analysis. So by this EFI, uh, the non-ART pregnancy, they have done the study, and they have done in the non-ART pregnancy rate at 36 months has been done for the EFI of 0 to 2, which is significantly increased to 69%, and then for a woman with EFI 9 to 10. So they have concluded by this study, take the next slide here. That EFI is a reliable staging system to predict the spontaneous pregnancy rates of the patients. The least function score was the most influential factor to predict the spontaneous pregnancy rate. Patients with EFI score of more than 5 after 12 months from the surgery are recommended to receive the IVF and embryo transfer to achieve a higher pregnancy rate. So the principles of treatment, as we are focusing today on the endometriosis, what are the challenges in the infertility treatment? So the principles in the endometriosis treatment is a pain relief, fertility enhancement and improvement quality of life, and the medical therapy or surgical methods, combination of medical and surgical, hormonal therapies, OCPs, GnRH agonists, antagonists, aromatase inhibitors has been also been reported, and to remove the endometriotic lesions and repairing the pelvic anatomy, and combining the medical and surgical therapy improves the outcomes and pain relief. So we can see here in the asymptomatic minimal endometriosis, observation of the 6 to 8 months and investigate infertility, while in symptomatic cases, drug treatment, minimal invasive surgery or surgery has been reported. In the drug treatment now coming, there are a lot of modalities are available. OCPs, either intermittently or continuous, with the high incidence of side effects of and thromboembolism limits the prolonged use. Then there is also be the regime has been reported. OCPs for giving constant 84 days, then with 6 days tablet free, reduces the menstrual period just to just 4 cycles in a year. Then oral progestogens, among this it is coming, act as a oral progesterone, act as anti-estrogenic effect, and their continuous administration causes the deserialization and endometrial atrophy. Norethistron in a dose of 5 to 20 mg daily or dydrogesterone 10 to 30 mg daily has been reported. The hormone does not prevent the ovulation and is suitable in the woman for trying to conceive. Other therapy was reported was also the use of the danazol and the letrozole. The danazole, it was reported in a dose of 200 to 800 mg daily for the period of 3 to 6 months. But now I think currently none of us are using the danazole due to these all side effects of weight gain, hirsutism, atrophy of breast. Now the aromatase inhibitors, the letrozole 2.5 mg and anastrozole 1 to 2 mg daily for 6 months. Anti-estrogenic and prevents the conversion of androgen to estrogen, should be given with vitamin D and calcium to prevent the osteoporosis. The side effects has been noticed are nausea, vomiting, diarrhea, and other side effects. Drug treatment, GnRH releasing hormone. GnRH is administered continuously to down regulate and suppress the pituitary gonadotropins, causes the atrophy of the endometriotic tissue. The synthetic analog of GnRH given the dose of 10 to 20 mg of IV also has been reported. But the prolonged use causes the hypoestrogenism, menopausal symptoms, hot flushes, dry vagina, urethral syndrome, and osteoporosis. And RU486 has also been reported, tried in a dose of 50 mg for 3 months, which reduces the pain and daily recurrences. The drug therapy, now what is the failure? Failure because drug cannot penetrate the fibrotic capsule. Ectopic endometrium responds less to hormones as compared to normal endometrium, so it prevents the conception. So the coming to the for laparoscopic surgery to diagnosing the endometriosis with biopsy and histology, the gold standard. A negative diagnostic laparoscopy, highly accurate for excluding endometriosis and decision making. Positive laparoscopy is less informative with limited value and without biopsy and histological confirmation. So now what are the challenges have been reported, whether or not to perform the laparoscopy surgery. So no standard protocol regarding this. So there is always a debate. So to do or not, the techniques what has been advised are CO2 laser ablation, excision or cystectomy, aspiration via ultrasound, drainage of the lesions following laser vaporization, and there are some studies have come via for the intra installation of ethanol or the GnRH also has been reported for the endometrioma. Again, the studies have been reported for cystectomy for ovarian endometrioma, reduces the ovarian reserve and iatrogenic infertility. Laparoscopy for early stages exhibits the promising results. So in the endometrioma, as we have just mentioned, it is observed in 17 to 44% of the patients with endometriosis. So the theories have been come the invagination of ovarian cortex secondary to bleeding, invagination of the ovarian cortex secondary to metaplasia of coelomic epithelium and cortical inclusion cyst, endometriotic transformation of functional cyst. Endometriomas can cause a lower oocyte quality and decrease the number of oocytes retrieved during the fertility treatment. Laparoscopy carries the risk of complications and damage to the ovary. So the mechanism what has been reported, the inflammatory reaction, increased number of immune cells, elevated cells levels of cytokines, chemokines, and reactive oxygen species, tissue fibrosis, as we know. While in the mechanical damage by compression and stretching of ovarian tissue, hampered blood circulation, and disturbed neovascularization. So the treatment for this has been reported to operate or manage conservatively, or excision is preferential. Ablative techniques are not suitable. For ovarian endometrioma, perform the cystectomy instead of drainage and coagulation. Cystectomy reduces the endometriosis associated pelvic pain. Performing cystectomy rather than CO2 laser vaporization in ovarian endometrioma to avoid the recurrence. So the challenges with this treatment at live birth rate is sparsely reported following surgery. The surgical resection before ART, conservative management, or direct referral to ART. So, post-surgical ovarian failure after bilateral endometrioma surgery has been also been reported. So, a very important point whenever we are planning for this endometrioma surgery, the pre and post-op AMH doing is very important. I think these days, so it is utterly important, because once we are treating the infertility patients with endometrioma, so these days we are having all the patients of the Google savvy. They have read everything on the Google and then come to us. So it is definitely, it is must to do the AMH reading before and after the surgery too. So only few slides are left. So surgical treatments on spontaneous conception, the pregnancy outcome, the rates of ovulation with unilateral endometrioma. The study has been done on the 6 ovulatory cycles, is reported up to 43%. While in higher pregnancy rate due to unilateral ovarian endometriotic cyst, no tubal disease and normal semen analysis. Prospective study of laparoscopic excisional and ablative surgery in 52 women with endometriomas more than 3 centimeter in size. At 6 months, 12 patients were pregnant, while in 8.3 months, 15 women were pregnant, around 41% that comes to. So there is one more study by the Italian group for the surgical treatment or versus the spontaneous conception. The studies have shown the spontaneous pregnancy rate is less in stripping versus the cystectomy. So they have shown the study on the recurrence managed by the ablation using the plasma energy in 83 women. In this, they have shown 61.4% as the 51 pregnancy rate and 33 the spontaneous pregnancy conception with colorectal and non-colorectal endometriosis. Also, the studies have been reported, and colorectal endometriosis management by ablation using the plasma energy does not affect the pregnancy rate, that study has concluded. So now coming to the impact of surgical treatment of endometrioma, the study has been presented by the meta-analysis by Gupta et al. That reduce the ovarian response to stimulation. Major limitation: patient previously operated for the endometrioma before IVF. Other study has been by the Young et al. It shows that significantly lowers the oocytes, metaphase 2 oocytes, and total embryos in endometrioma. Similar rates in gonadotropin dose, stimulation, number of good quality embryos, implantation rate, clinical pregnancy rate, and live birth rate. While in this, the systematic review and meta-analysis of IVF and ICSI outcome, 37 studies selected, including the 30 retrospective and 3 randomized controlled trials. They have shown the live birth rate with IVF ICSI versus control and clinical pregnancy rate, lower the number of oocytes retrieved, higher cycle cancellation rates compared with control. So the studies have been suggested the previous intervention for endometriosis, which favors surgery or favors expectation in the ovarian reserve intact, while in other is damaged with the pain symptoms present or absent, bilaterality or monolateral disease. So we can see in the surgery favor the monolateral disease, sonographic features of malignancy present, and if there is rapid growth, while in expectant management, if ovarian reserve is damaged already, so then either we this electrocautery of something or is used, it will more damages the AMH. And the bilateral disease favors the expectant management. Yeah. Uh, So, what are the challenges has been noticed in the IVF treatment? Lack of clinical signs delays the diagnosis. Controlled ovarian stimulation protocols can cause the recurrence. Endometriosis is an estrogen-dependent disease. A relationship between RAF and endometriosis has been noticed in IVF. So, overuse will futile results. The challenges of failing to diagnose and treating as an unexplained infertility uh, and natural conception after surgery. So the ISHRE guidelines that IVF post-operatively with tubal or male factor has been the come from that guidelines. So we can see in the last what's the algorithm if the female with suspected endometriosis, the infertility workup. So especially if the patient is having grade 1, grade 2, please go for the IUI. Don't waste the time. If the patient is having the grade 3 or grade 4, direct IVF or ICSI, it will be the best. And the ovarian reserve testing, the poor ovarian reserve or old age, suspicion of minimal or mild endometriosis, suspicion of moderate to severe. Then the surgical treatment, then as I told, combined ovarian stimulation and ovarian IUI for 3 to 6 cycles. Then still if the result is not coming, directly switching over to the IVF or ICSI. So I think this we have already discussed. Yeah. So the treatment of endometriosis associated infertility. So no hormonal treatment for the suppression of ovarian function in infertile women with ASRM guidelines. The stage 1 and stage 2 operative laparoscopy, adhesiolysis, while stage 2 and 3 CO2 laser vaporization. No monopolar electrocoagulation since laser vaporization is associated with in infertile women with ovarian endometrioma, excision of endometrioma capsule instead of drainage and electrocoagulation of the endometrioma wall, while stage 3 and stage 4 operative laparoscopy instead of the expectant management. While in the hormonal, the what the studies have concluded from the Human Reproduction Journal also, that no adjunctive hormonal treatment before surgery to improve the spontaneous pregnancy rates before and after. Then the ISHRE guideline has suggested that IUI with ovarian stimulation instead of expectant management of IUI alone. Then IUI with controlled ovarian stimulation within 6 months after the surgical treatment, use of ART after surgery, antibiotic prophylaxis at the time of the oocyte retrieval, GnRH agonist for 3 to 6 months prior to ART to improve the clinical pregnancy rates. So the studies have suggested if the endometrioma more than 3 centimeters, cystectomy prior to ART does not improve the pregnancy rate. Yeah. Counseling the female with endometrioma, the risk of the reduced ovarian function after surgery, loss of ovary, and the role of OCPs for prevention of endometriosis is uncertain, and role of physical exercise for prevention of endometriosis is also uncertain. So the studies have been supported, again this from the Journal of Minimal Invasive Gynecology. In they have studied the 53 women of the endometrioma measuring 4 to 10 centimeter with no malignancy intervention, laparoscopic aspiration, and 95% of the ethanol sclerotherapy has been reported, in which endometriomas are aspirated and washed to remove all the cystic material. 95% ethanol solution is inserted for the 15 minutes and then removed, and they have done the study via this. So conclusion that in this the age group of the patient were included from 19 to 40 years, diameter mostly the 6 centimeter 4 to 10. They have concluded from this that laparoscopic aspiration and ethanol sclerotherapy in patients with bilateral endometriomas is associated with deep endometriosis and less than 10% recurrence and no major complications. So the conclusion have come, the presence of endometrioma has no detrimental effect on the ovarian reserve. Surgical excision of the endometrioma had negative effect on the ovarian reserve. This is very, very important. With female with unilateral endometrioma showed a higher rates of spontaneous conception. Number of oocytes and metaphase to oocytes are retrieved, and the total embryos are significantly lower in the endometrioma. Implantation rates, clinical pregnancy rates, and live birth rates are similar. The surgical treatments for cyst more than 3 centimeter prior to ART, no evidence that cystectomy prior to the treatment with IVF and ICSI improves the pregnancy rates. So excision surgery provides favorable outcome than drainage and ablation in recurrence and spontaneous pregnancy. Uh, Evidence have suggested that laparoscopic aspiration or cystectomy prior to ART did not show benefit over the expectant management. Then the trials have shown the ovarian response to combined ovarian hyperstimulation was greater than after expectant management than the cystectomy. So final message is coming. So the treatment should be tailored according to the symptoms, fertility wishes, and cyst characteristics. As a general rule, surgery in the case of pain, unilateral lesions, and no previous surgery, intact ovarian reserve, and no malignancy. In case of opposite circumstances, conservative management plans. Surgery involves stripping and removal of cyst. Ablation methods, the recurrence is higher and not effective for pain. Drainage is another option for relieving of pain. Aspiration increases the response of IVF. So endometriosis itself is a full mystery. So very difficult to summarize all this in such a nutshell. So I will end with this quotation of this from the Sir William Osler: "The he who knows the endometriosis knows the whole gynecology." I hope all of you again agree with me on this. It's totally mystery in the endometriosis. So thank you to all of you, and thank you once again the Shield Pharma for inviting us here. With this, I'm stopping the sharing here.
Yes.
Yeah.
Thank you, madam. It was
Yeah.
a very excellent and very detailed talk.
Thank you.
And we have Dr. Rajshree Katke madam here.
Yeah. Sorry, I was stuck up in the meeting, and then there was so much of heavy traffic. I have to rush, and
Yes,
Okay.
ma'am.
I came back.
Anyway, thank you for joining, ma'am.
Uh,
Uh,
okay, so can I start or?
Yes,
Madam, we have one question,
Uh,
so we will address and then we will.
No, first Dr. Rajshree will take lecture. I will be here. Let Dr. Rajshree finish. I will be here. We will answer questions jointly.
Okay, ma'am. So we will
Yes.
continue with Dr.
Yes,
Rajshree madam topic.
yes. Yeah, please introduce first, ma'am.
Yes.
Welcome, Dr. Rajshree, a
Hi,
very
hi.
dear friend of mine.
1 minute. I'll just.
No, let them introduce you first. Dr. Rajshree, wait, don't share. First, they will introduce, na? Yeah.
Okay.
Yeah. Good evening, Dr. Rajshree Katke ma'am. Thank you very much for joining today's webinar. It's an honor to introduce you, ma'am. Actually, she is a
Thank you.
professor and head of the department at OBGY Grand Medical and Grand Gort Medical College, Mumbai. And coming to the academic, she is a professor and head of the department and medical undergraduate and postgraduate for 24 years and ex-committee member of Mano Dhairya PO's CO and
Posco.
POSCO.
ठीक
And
है.
yeah, around
Proud.
150 papers were presented under my guidance, her guidance, sorry. Research and editorial author for 85 publications and 171 citations in the national and international, and contribution for chapters in Foxy Focus, co-editor in book Foxy. And coming to the awards and appreciation, she was appreciated by the General Secretary of United Nations, Hon Ban Ki-moon.
ठीक है.
And award for
Someshwar, it's okay.
Actually, there is more things to share regarding Dr. Rajshree madam.
No issues. I'll share the screen. They know.
Yes, yeah. And also one more thing to say, she is a member of Task Force in Ayush for COVID-19. She's doing a wonderful job in this regarding this COVID-19. Thank you very much, ma'am.
Thank you. Can I
Dr.
start?
Rajshree, wait. One very important point for Dr. Rajshree's introduction. I will introduce her in one line. A friend in need is a friend indeed. So she is like that.
Thank you.
Duty with brain. She is always ready to help.
Beauty.
Yes.
जो उसके close friend है वही बता सकते हैं ये. So
Yes, I agree.
Yeah.
Yes.
Now over to you, Dr. Rajshree.
Yeah, please. Thank you. Thank you, Someshwar. Thank you, Ritu. Yeah. 1 minute.
Your slides are visible.
Visible, no?
Yes.
I'll be talking about gestational diabetes. Basically, these are the two different topics and two toxic topics. One is obstetric diabetes and second is endometriosis. Those who knows diabetes, they know the obstetric, and those who knows the endometriosis, they know the gynecology. So gestational diabetes is defined as any degree of the impaired glucose of with onset or the first recognition during pregnancy. Many are de novo pregnancy induced. Some are type 2, which contributes around 35 to 40%, and 10% do have antibodies in it. So what is the magnitude of problem? Because I just like to, highlight what is the global thing in that prevalence of GDM varies worldwide and among different racial groups within the country. America, white women 3.9%, Asians 8.7%, Europe 0.6 to 3.6%, Australia and the China is around less than 3%, and variability is depending upon the different criteria and the screening regimes. So in Maharashtra, we are having around 7.7% and Trivandrum 15%, Bangalore 12% in the India. So basically, what is a pathophysiologically of the gestational diabetes? One is the insulin resistance, and second, due to the placental secretion of the anti-insulin hormone. Second is a pancreatic beta cell dysfunction caused by either the genetic or the autoimmune disorders or the chronic insulin resistance. And if I can see that the slides there, I have to take it up actually. Just a minute. So okay, so basically maternal glucose intolerance in the late pregnancy, that is one of the thing in that. Then we will come to the risk associated with the, preterm maternal risk and the fetal risk. Maternal preeclampsia, increased cesarean delivery, subsequent development of the type 2 diabetes, 30% maternal mortality rate, depend with the complication like toxemia, anemia associated with the diabetes, progression of the chronic complications of the diabetes, gestational hypertension, hypoglycemia, ketoacidosis. It is a multi-systemic disorder. Sometimes all the systems, if there is uncontrolled diabetes is there, that is going to get affected. Fetal risk, childhood obesity, hyperbilirubinemia, birth injuries, macrosomia, hypoglycemia, hypocalcemia, RDS, premature birth. So these are the some of the complications in that. Congenital anomalies, this is the most worrisome part nowadays because we are having 2D, 3D ultrasound sonographies. We are detecting most of the anomalies into the first trimester. So, and the second trimester. So basically what I would like to highlight is that most of the 2/3 of the CVS or the CNS, these anomalies are around 20 times common in a diabetic pregnancy. The cardiac, including the great vessel abnormality, like a transposition of the great vessels, TOF is there. Then central nervous system, one can get a anencephaly, holoproencephaly, then spina bifida, open neural defect 7.2%. Then skeletal are the cleft lip, cleft palate, caudal regression syndrome. This is very common. Genitourinary tract, ureteric duplication, and the GIT is anorectal atresia. So this is a very important thing. This I would like to highlight because these are the new concepts they are coming. Fetal programming in GDM. What happens fetal program? Adverse environmental insult during pregnancy may lead to the disease in the further life. So what happens if suppose scenario we have a overfeed state of the GDM that causes the early exhaustion, and this leads 1 minute. Early exhaustion, and this leads to the early beta cell exhaustion, and that going right to give to the future type 2 diabetes mellitus in the babies. Then programming over for the overproduction, fetal pancreas secretes the higher than the normal insulin. So I would like to explain to you underfed state in the maternal starvation, where the fetal pancreas production capacity gets compromised. Programming for the underproduction, the fetal pancreas produce less insulin. I would like to say one thing is that what happens to this maternal hyperglycemia, maternal sugar goes transferred to the fetus, but the mother's insulin is not going to that. So the fetal pancreas, they get or beta cell hyperplasia, and that secretes the insulin because of the maternal hyperglycemia leading to the fetal hyperglycemia, and that is giving rise to the pathophysiology into the fetus like macrosomia, deposition of the fat, polycythemia. Then there could be sometimes development of the ascites also, and all these complications which is dealing with that. But this is into the introitrine, but we are more worried about the future. So future type 2 diabetes mellitus, this can be happen. So basically it should not be a maternal starvation, or it should not be overeating state. So it has to be, the diet has to be managed very properly. That is what I would like to highlight here, because here we are not worried about the lady, the pregnant woman only controlling of the diabetes, but we have to control the diabetes in such a way that keep future for her baby or for herself, she should not get the victim of the diabetes. This point I would like to highlight, so I am explaining more in detail. So underfeeding and the overfeeding, both the red line, it gives the idea about the the disease one. So what it happens, it has to be adequately fed. WHO classification of the diabetes: type 1 diabetes mellitus, type 2 GDM, and other rare forms of the diabetes mellitus. Then glucose intolerance recognized for the first pregnancy, closely associated with the symptoms. And third is the insulin resistance is common to both GDM and type 2 diabetes mellitus. So what happens? Why don't all pregnant women develop the GDM? So what happens in a pregnancy? The placental hormones, this can cause the insulin resistance. Once post the placenta is removed, all the hormonal actions of the insulin resistance, it comes to the normal, and then we can say gestational diabetes can give rise to normal blood sugar levels, and that is why we called it is a gestational diabetes mellitus. So what happens in a GDM? Pancreas reserves are lower. Women with a history of GDM have likelihood to developing GDM in a future pregnancy. The main reason for this high probability is that as time goes, the functional reserves of the pancreas are reduced, and this is very important thing. Then comes to the, this is the time of the years where, you know, first pregnancy, second pregnancy, and in developing the type 2 diabetes mellitus. Then these are the risk factors we can say for this gestational diabetes mellitus in a previous pregnancy. You suspect it. Body mass index more than 25 kg per meter size, can say, you know, obesity. Then ethnicity, like Asian, Native American, Pacific Islander, Black or Hispanic women, they have the depending upon their this thing area, they can develop the risk of the diabetes in the first pregnancy. It has a relatively risk to develop in a second pregnancy also. Then weight gain in the mother, maternal age older than more than 35 years, and the gestational weight gain in excess of Institute of the Medicine guidelines, and the macrosomia in the previous pregnancy. So what we should see is that patient elderly primi gravida, obese women, BMI more than 25, ethnicity, and she has any history of the diabetes in the family or herself in a previous pregnancy. So, and GDM, we say COVID is an epidemic. So just now we have a very nice, conference on the non-communicable diseases with the ICUG FOXI. There also I spoke on that, how to reduce the maternal mortality rate with control of the NCDs. What is the role as at the institutes? So basically, results from the women in India and the GDM program jointly conducted by the Diabetes Federation of the and Diabetes Research Foundation everywhere. So what is the problem? So high prevalence is the one of the problem. In India alone, GDM affects 5 million women each year. So that's the serious problem. You have to come to the pre-diabetic, and the diabetes affect the approximately 6 million births in the India, and most of the cases either subclinical or the underdiagnosed, that gives the complication during the in a postpartum GDM. So GDM India perspective, here we can say diabetes diagnosed in a second and third trimester of the pregnancy. In India alone, GDM complicates nearly 4 million pregnancies annually. So fetal origin of the adult disease, that is what we can say with the hypothesis. Then comes to the government of India, mandate to screen all the Indian pregnant women for the GDM. But basically, if you can say that, it has to get, you know, operationalized at the primary healthcare level. But I think state of Maharashtra, all the state government, they are developing all these diabetic clinics, and we are doing a very good work in screening all these gestational diabetes. So urgent need to curb this epidemic. Why? So basically, universally, you have to screening for the first trimester, use of the single step of the OGTT 75 gram, part of the routine assessment of the woman to see whether there is any high risk case or not. Then preventive steps, you have to see what prevention, how will you do? You have to educate the patient. Then medical fraternity, CMEs and the education and the early management. This is how we have to curb the epidemic. Then comes to the, you can say that American Diabetic Association and the WHO fasting. Here we can say is that 95, it is the cutoff line, 1 hour, 180 milligram, then 2 hour, 155 in ADA, and WHO says more than 140. We are falling more than 140. Then comes to the women and when to screen in the Indian scenario, 75 gram GCT with a single dose at 2 hours. Then if you can say that if single 140 milligram or more than 140 milligram blood sugar is there, then you can say suspect of GDM in that, and then more than 120, you can say you can go for a direct GCT. Then universal screening, first trimester, if negative, go for a 24 to 28 weeks. Why? Because second trimester, the insulin resistance is more. So you can say we can screen it out even for 24 to 28 weeks, then 32 to 34 weeks. Here the we can say that complications, hypertension, other complications, stillbirth, miscarriage, preterm labor, and the preeclampsia. Then Madhura Wagmare, please you just unmute yourself. National guidelines by the Ministry of the Health and the Family Welfare. Please listen to that. Pregnant women in the community, testing for GDM at least first antenatal visit 75 gram. You can do with the 2-hour plasma glucose level. If it is more than 140, manage as a GDM as per the guidelines. If suppose negative is there, don't think that she doesn't have a diabetes, repeat it at 24 to 28 weeks. Then if it is positive, manage as a GDM. And if it is negative, you can manage as a normal ANC visit. So basically you have to screen. Screening is very, very important. So management issues. One is important thing is that patient education, then medical nutrition therapy, pharmacological therapy, glycemic monitoring, self, blood glucose monitoring, and their targets, fetal monitoring, and the planning on the delivery. These are the various components where one should look for the how to go with the diabetes. These are the some pictures, but what you should do for the diet, we'll talk on that. So what are the goals? First is you have to achieve the normoglycemia. The patient should be a normoglycemic. Little hyperglycemic in pregnancy is considered is okay for that. Prevent the ketoacidosis, prevent the hypoglycemia, provide the adequate weight gain. This is very important. We don't want to underweight mothers during pregnancy. We don't want to overweight mothers also. And contribute to the fetal well-being, because in you can say in a diabetes, even in a controlled diabetes, there is a chances of unexplained IUFDs. So you have to contribute a well amount of time and your observation for the fetal well-being. Then comes to the nutritional plan or the dietary management, calorie allotment, calorie distribution, and the carb intake. So how can you divide it that? There are some general rules. 30 kilocalorie per kg current weight per day in a pregnant woman who are having BMI 20 to 25. The more the BMI, the calorie should go less. Okay, if suppose 26 to 29, 24 kilocalorie per kg, then BMI is more than 30, then you steadily go on a 12 to 15 kilocalorie, and you can take all these in a what we can say is that you have to distribute the meal accordingly, according to the need of the mother and the baby. Then comes to the carb intake. Postprandial blood glucose concentration can be blunted if the diet is the carbohydrate restricted. See, we want a complex carbohydrates such as those in starches and the vegetables. It is being recommended because it causes the slow release and it gives the good glycemic index. Carbohydrate intake is restricted to 33 to 40% of the calories, and you should you should tell them to take more of the proteins and little bit of the fat. So with this caloric distribution, 75 to 80% of the women with GDM will achieve the normoglycemia. It is very, very important to have a good diet control. So in a valuable opinion, So you can calculate the calories, then according to that, and then in the breakfast meal should be a small, preferably 10% of that, to help to maintain the postprandial euglycemia. This is very important. Avoid so much of carbohydrate intake during the breakfast. Then to the lunch for 30% of the total calories, dinner 30% of the total calories, and the snacks in between you can have for that. So how to monitor? Second, we have seen about the diet. Then how to monitor the blood glucose level. Home monitoring, we have to educate the patient. They can have a glucometer at home, and they can maintain a logbook. This is very important. But I always tell them to put a dates, then your blood sugar levels, and then you at home what we are doing, postprandial and the fasting, they can make a 2 columns in that, and blood sugars and what tablets they are taking. And then after 7 days, if any fluctuations are there in their blood glucose, then they can go immediately to the doctor. But maintaining of the logbook is very important. We have to educate the diabetic patients. Then use a memory meter, calibrate the glucometer frequently. This is also very important. You cannot keep it like that only at a same caliber. Then hemoglobin A1C, it is very important. It gives the idea about the 3 months, glycemic control. It is an ancillary test for the feedback to the patient, lower values when compared to the non-pregnant state. So basically our target is less than 5.1, but I can say less than 6 or less than 6 also, it is good for good control. Then comes to the glycemic targets. ACOG says fasting venous plasma, it should be less 95 or less than that, 1 hour less than 140, and 2 hour less 120, less than 120. The pre-meal less than 100 milligram per deciliter, or AIC less than 6%. This you have to manage it in that. And ADS says the same pre-meal 80 to 110 milligram, and 2 hour post meal not more than 155. So basically we are taking 140, and with the American Diabetic Association they are taking for the 155. If the fasting FBG at diagnosis is more than 120, can consider immediately for the therapy, because our cutoff line is 95. So if it is going for that, then one should go for the immediate therapy. Then okay, so now how should go with the medical line of treatment? In that is the insulin, more than 15% of the need of the insulin. Total dose varies. We can start with the 0.7 to 2 units per kg. This is how some of the landmarks are there. Fasting blood glucose level, if high, in a night NPH, you can say 0.2 units per kg. And postprandial is high, then we can give with the bolus 1.5 units per 10 gram. Okay. Here we can say if the patient is hospitalized many of the times, then we can do a sliding test. Then how we should go for the sliding test is that what is the units required and how much is the blood sugar. So if both pre and postprandial blood glucose high, or if women's postprandial glucose levels can be blunted, then starvation ketosis occurs. That's why we always say that you should not have a much of the fasting hypoglycemia, and there should not have a most of the postprandial hyperglycemia. So it can prevent the complications. Total 0.7 unit per kg up to 18 weeks. 18 to 26 weeks, you can go for a 0.8 unit, and 0.9 unit for 26 to 36. Means basically you can start with the 0.7, then 0.8, 0.9, and then 1 unit per kg for weeks of 36 to term. But in a morbidly obese woman where the BMI is more in that, sometimes it can require 1.5 to 2 units per kg to overcome the combined insulin resistance of pregnancy and the obesity. Then what is the role of OHA? See, when the old age, whenever there is a pregnancy, we always used to go for the insulin. But now they are having the oral hypoglycemic agents, and a systematic review by the Johns Hopkins University, where the maternal glucose levels did not differ substantially between the gravitrine and the insulin versus those treated with the oral glucose lowering agents. Means there are some of the oral hypoglycemic agents, they are giving the good glycemic control. So there was no consistent evidence of an increase in any adverse maternal or neonatal outcome with the use of glyburide or a carbose or the metformin. So we will see one by one. See, tolubutamide and chlorpromamide, these crosses the placenta. We are not using this. So what is the next? Glibenclamide, minimal transplacental transport. Then observational studies, no excess anomalies or hypoglycemia. So basically, this is, they have done a random control trial of 404 women, and there is a no difference what they are saying in that. The second generation, these are the some of the promising drugs in this second generation sulfonylurea, especially glyburide, do not significantly crosses the placenta, and the fetal concentration only 1% to 2% of the maternal concentration. We don't want much of the fetal concentration also. It has to be an adequate balance of maternal concentration also and with the fetal concentration also. Tolubutamide crosses the placenta most freely, followed by the chlorpromamide. So, and the list is the glyburide. So basically what we can say that we don't want drugs to be passed so fastly through the placenta, and it can make the fetal hypoglycemia in that. Metformin crosses the placenta but not teratogenic in the rat models. So there is again a question whether they are safe in a first and second trimester. So let us say about that. Metformin, it is a category B drug, no adverse outcome after first trimester. Second, third trimester, safe and effective. I always say that even the last, even one of these, I was on the panel, and there also I said the same thing, metformin. If you can avoid in the, for the PCOS also, if we started in the on its metformin and she gets conceived, so you can avoid for the first trimester and you can go for a second and third trimester, which is safe and effective. So metformin versus insulin, no serious adverse effects, no studies versus the glibenclamide. Carbose 2 means these are not having much of the studies in that. So let's have what has been the current treatment modalities available. One is a metformin, where the pros are it attacks the insulin resistance, and metformin we are using, so it has a many of the studies has been come up with the metformin. The cons is that does not prevent the GDM, cannot manage severe cases, because if there is high blood sugar, then it cannot manage with the metformin, and not tolerated by all. Some they have a side effects of that. Crosses the placental barrier, but fetal risks are unknown because it is a category B by US FDA. Then comes to the insulin. What are the advantage? It is efficacious. Then disadvantage, worrying problems are there. It is injectable, the compliance is poor. It can happen with the it can give rise to the sudden hypoglycemia, then the weight gain, large babies, macrosomia is common with the insulin, unable to prevent the complications of the GDM, and does not tackle the root cause. Then comes to the third thing is inositols. The pros are both prevents and manages the GDM, attacks the root cause of the GDM, and leads to favorable fetal and the maternal conditions, shown to be superior to the metformin. They say there are some studies. Let's to have a look in that. So members of the inositol family regulate the insulin signaling. If you can say in that, these are the cell membrane. With the cell membrane, there are the insulin receptors, and these inositol, they can regularize the insulin signaling, and that is very important in a diabetic management. Okay. So the combination of the MI, that is a myoinositol, and the DCI, which acts as a gatekeepers for the insulin signaling on the glucose metabolism. Then necessary, what does causes the myoinositol? It is necessary for translocation of glucose transporter to the cell membrane. Then comes to the regulates the glucose cellular uptake. This is very important because we want at the cellular level, there has to be regulation at the cellular uptake. Then comes to the DCI, we stimulate the pyruvate dehydrogenase, and that can cause to the necessary for the ATP production by regulating the Krebs cycle. This is very important. All these effects take place when MI and DCI are in combination. So basically in a GDM, myoinositol levels are 36%, and they says in a normal pregnancy, the DCI levels are lower by the 50% in a diabetic. So they are deficient in that, and if you give this to the mothers, then it can develop a good glycemic control. So what happens to that? Whenever there is a DCI production decreases, the epimerase activity gets lowered, and there is a high insulin resistance as shown in the figure. Then comes to the this myoinositol and the DCI. If you combine in that, that can normalize the insulin signaling at the glucose metabolism. See, it is little bit, you may be finding it is difficult, but I'll tell you, the most important thing is that in a pregnancy, one side there is a insulin resistance, second side is that there is the uptake of the glucose at the cellular level, there is also dysfunction in that. So we want the drug like this, which works on this signaling of the insulin and the cellular uptake levels, that can control the blood sugar at a cellular level also, and at the secretion level at the insulin at the pancreas also. So we want that sort of thing. So blood glucose should be this thing. So these are the various studies where they have done a group A. There is only myoinositol, and this group B, folic acid. So what the results are there? So in that there is a 80% lesser GDM cases with the myoinositol. Then comes to the group A. This is a randomized control trial, and it has been published in a diabetes medical around journal of 2011, where the 8 weeks therapy they have planned with the group A with the myoinositol with the folic acid, and group B is only with the folic acid, and the result has been found that this is a little bit ulta, but 240% better decrease into the fasting glucose with the EMI, means myoinositol. So it gives the good amount of the control. Okay, so inositols versus the insulin, let us see what it does, gives the idea about that. They have studied, the sample size is less, 32 sample in a group A, and 28 with the insulin. Let us see with the insulin group. So in a 75% of the lower insulin uses during delivery with the myoinositol, means if these sugars they are get very much in control, you will require a less amount of the insulin. That is what we needed in this. So so let us see how it gets this synergistic effect of 40:1, which myoinositol regulates the cellular glucose uptake, and the DCI regulates the utilization of this intracellular glucose into the energy. And this is very important because the cell has to be active, and even the Krebs cycle has to be maintained in that. So safety parameters similar to vitamin B complex, it is a water soluble. That's why they say no side effects if you give till 4 grams per day. But if you resist the dose, then they have a loose stools, nausea, flatters. It's like that in. So these with this, if you are using this, then they have a less chances of the respiratory distress syndrome, macrosomia complication. If there is no macrosomia, shoulder dystocia, birth injuries will be less, and there is a less chances of the preterm deliveries. So basically all is coming with the euglycemic control, how you should control the blood sugar in the diabetes in pregnancy. So the trials reviewed in this meta-analysis conclusively reveal following points. Myoinositol therapy, it prevents the GDM if initiated right at the start of the pregnancy, and it effectively manages the GDM. So this is a big Cochrane review. In that I have just highlighted the summary of the main results that says that it appears that myoinositol shows a promise in reducing the risk of the gestational diabetes. Let's hope so. We want the drugs which can help in that. So diagnosis of the GDM, the risk factors at the booking appointment, determine the BMI. We can say that, obese patient, BMI more than 30. Then macrosomia, recurrent pregnancy losses, mother is having diabetic, congenital anomalies. In such cases, one should go for the risk factors. If you feel that the mother is very high risk, then we should go for the screening. So I have already explained to you how we should go with the 75 gram of the oral GTT, how you should screen with the first coming. Then if it is negative, then do it on 24 to 28 weeks. Then again in the 30 to 36, 30 to 34 weeks also you can screen twice to say whether she is normal blood sugar or not. So antenatally, what care you should be taken? One is the health education, that is very important. I have told you how much calorie it should go according to the body mass index, and the diet. Then what carbohydrates she should take, more amount of the proteins, then less of the carbohydrates. Then simple carbohydrates you should avoid it. It should be a complex, saturated one. That has to be that should come from the vegetables and all. So this is the diet. We have seen what you should divide into a breakfast, then the lunch and the dinner and the snacks. In a medical nutrition therapy, the importance of the diabetic diet, micronutrients, macronutrients are very important in that. The most important thing for the diabetes is the physical activity. There are studies where they says if you walk also for 40 minutes, brisk walking can release most of your energies. They can regulate that, they stimulate the pancreas, then the regularization of the blood sugar will be in a normal. I mean, people, they have come from around 8 of the glycosylated hemoglobin to 6, and they have controlled with the 5.1 also. So physical activity is very important. So but in a pregnancy, we have to do the activities according to what suits to you, how much you can do. You have to take care of the pregnancy, but only sitting down, it will unnecessarily raise the blood sugar level. Then pharmacological therapy, we have seen all these second generation metformin, second generation sulfonylurease, then insulin therapy. Then comes to the blood glucose monitoring is very important in that. What should be your target blood glucose level? We have already spoken that fasting 95, it should be less than means less than 140 at 2 hour, and less than 120 at a less than 140 2 hour, and less 120 to less than that in a 1 hour thing. So ketone monitoring is very important. They have a heuristics and the glucose sticks also. I always tell them, whenever you are doing, just see the urine protein also, sugar also, and the keto sticks. If you have in combination, doing that. Hemoglobin A1C monitoring is very important for the self monitoring in that. Whenever you get a chance to give the blood, then you should go for this, at least for 2 monthly checking in that. Continuous glucose monitoring, it is always in a supervision. Fetal monitoring is very important. See, in a first trimester, second trimester, first trimester, do a very good sonography, rule out all the congenital malformation. Then malformation scan should be done at a second trimester. And if everything is fine, then one should go for the antepartum fetal surveillance, use of the Doppler, the parameters, then amniotic fluid index, biophysical profiles. Then if it is uncontrolled diabetes also, then hospitalize, and you can monitor mother and the fetus. Then timing and the mode of the birth. This is the most crucial part. Suppose you are in a 34 to 36, what you say, if suppose the IUGR babies, I want to induce at a 34 weeks, I'll get a good maturity. Even at a term baby, you get a good lung maturity. But here what it happens, the lung surfactant or the alveolar cells, that has the problem with the this thing. So you can you get lung hypoplasia or the hyaline membrane disease, more common with the uncontrolled diabetes. So here the respiratory function or the lung maturity will not be at the same as of the gestational age. Means, for example, if suppose at a 37 weeks, a normal baby has a better lung maturity than the diabetic, though the diabetic has a macrosomia or the higher weight version. So you have to be very careful while inducing such patient, because here you are not worried about the more of the weight, but you are worried about the lung maturity also, because we don't want that we have to deliver the baby up around 3.5 kg, and then it should go in an ICU, and there should be shouldn't be any respiratory problems or the respiratory distress to the baby. Glycemic control, women should be closely monitored during labor and the delivery. And maternal glucose, this is given in a millimole, but we have already explained in that. Then neonatal hypoglycemia. So first, how to manage the birth. So first stage of the labor, patient hospitalized, keep everything ready, monitor the blood glucose, do with the sliding scale with the insulin. Screen the patient whether she may require the cesarean section at the 0 hour. Then such patient should go and take the anesthetist fitness. See to that you should have some pediatrician available or availability of the NICU, because we don't know in that these babies, they can go in a fetal hypoglycemia, hypocalcemia, polycythemia, respiratory distress syndrome, and many complications, and frequent hypoglycemia can lead to the sometimes a dreaded complications. So you have to be very careful in that. Good neonatal, good pediatrician should be there. This is postpartum, and during delivery, I have not made a slide of that. But while delivering, if just take care of this patient, first stage, second stage, monitor the partogram and whether the patient is having a good progress. At the same time, a descent of the presenting part, if that is good and pelvis is adequate, give for a trial, because such babies with the macrosomia, they can go into a shoulder dystocia, and sometimes it becomes very difficult, birth injuries and all. So tackle such patients, with the alert line and action line with the partogram, and such patients can be taken for at a timely cesarean section if it is being required, rather than taking out the injured baby with all these complications. So go for a whenever it is required for a cesarean section, take the baby. Otherwise, if the baby is at of average size, then you can go a normal delivery also, and that you can monitor also. So this is postpartum care. Once what it happens, when the placenta has come out, then the need of the insulin will become down. Then you can switch over to the patient to the oral hypoglycemic agents, and you can monitor that, give a good cover of the antibiotic. And then after that, monitoring in that patient, you counsel them for the contraceptive advice. Then information and the follow-up. Women would be informed about the risk of the future diabetes mellitus, hyperglycemia in future pregnancy. That here to explain her, and what is the importance of the lifestyle, weight control, diet, exercise, should not be a smoking, alcohol, or the drug consumption. So that has to be again told to the patient. Postnatal blood glucose testing at a 6 to 12 weeks to exclude the diabetes mellitus. So I think in summary, we have the range of the drugs like, metformin and glyburide, and then myoinositol and DCI can prevent the GDM if given in early pregnancies. And it can be, established cases also. We can have the trial with that. And we are using all these drugs. The drug of this myoinositol dose is of around 4 grams per day. And then this can give rise to a healthy pregnancy. And the references are from the European medical and pharmacological sciences journals, then current diabetes reports, diabetic journals, perinatology, and gynecological endocrinology, diabetes and metabolism. All of you have heard me very patiently. And so thank you, everyone. Thank you, Prachi. Thank you, Dr. Prachi. And thank you, Dr. Someshwar. So inviting me, for giving me a talk on such a, a complex topic. Always in a diabetes, it's difficult to understand and more difficult to manage. And because there is a crucial thing where you can say that you have to be manage the mother and the baby, and sometimes we manage and still you cannot get the good outcome out of it. So always it is being challenging, even in this era also. And good, we are getting drugs like, metformin or myoinositol and DCI. If they are MI plus DCI, if they are developing, helping into the good glycemic control and prevention of the GDM and giving good neonatal outcome, then it is the good thing for the future. Thank you, Dr. Ritu also. And sorry, I was late. It was difficult, to coming from the meeting also. So I came in a hurry. Thank you very much.
Thank you, ma'am. Thank you very much for an excellent talk. It's an always honor and learning to hear you, ma'am.
Yes.
Indeed, a very, very, very nice lecture, Dr. Rajshree.
I heard of yours. That was also very nice also. And it's a good, two topics to see, endometriosis and diabetes.
Both are difficult.
as a student, I used to get scared of both the things because I have never remembered the classification of endometriosis. So many classification, and diabetes is always, so many doses, so many insulin, so many classifications. So, but it's very good thing nowadays, we are giving them to nutshell points, and you have been so much of the experienced IVF specialist. So all these points, it will be helpful for them. And even the diabetes, they are having a big bunch in a high risk pregnancies. So I think they
True,
will
true.
be beneficial out of it. Okay.
Yes. Thank you. I think I can take that question now. There is one question in the FIT. Yeah, yes, same now. What we are able to see in the chat box, Dr. Someshwar?
Yes,
Yeah,
ma'am.
yes,
Same
yeah.
question.
In FET cycle, is it necessary to go for GnRH down regulation and then transfer? Is there any difference between GnRH down regulation or no down regulation in FET? I want to know whosoever asked the question, is this is asked especially pertaining to endometriosis patients? Is it anything mentioned in that question?
No, ma'am. It's from
Okay.
Dr.
No. In
Komal.
general, they have asked on
Yeah.
infertility.
Huh. No, that's correct, because yes, preferably we will prefer for going for this GnRH down regulation. GnRH down regulation we prefer in the cases of this, of course, in the endometriotic patients, because this topic is related to endometriosis and infertility. I think that doctor has must ask regarding to related to that. Yeah, is there is any difference between GnRH down regulation? Of course, see, the success rates are more in the cases of the with what the studies have suggested, the Cochrane data, ISHRE, and ASRM guidelines. What all have given the conclusion that success rates in the term of the live pregnancy rate are more in the cases of this down regulation cases. So, of course, we will prefer to go for the down regulation in the cases. Yeah.
Thank you,
I
ma'am.
think the lectures are both the lectures must be very informative. So no many questions, but I think they have heard of the most of the lectures nicely.
Ma'am, we have one more question. That
Hmm.
is, I think, for Dr. Ritu. Is there
Yeah.
a place nowadays for a medical treatment of deep infiltrating endometriosis?
No. Let me the name of the doctor who has asked this question.
This is from Dr. Ratna.
Okay. Dr. Ratna, see, for deep infiltrating endometriosis, there are some studies have come regarding the use of this letrozole, but though not very confirmatory, but there's, yes, of course, there are some studies have come for the extensive use for this letrozole have come. And in my presentation, one point, because due to the paucity of time, I can't include everything. For endometrioma, we are giving for endometrioma. And endometriosis, some studies have come for the regarding the use of this cabergoline also. So there are some studies which have shown the use of the cabergoline also 0.5 mg bi-weekly, minimum up to the period of 6 weeks to 8 weeks, also have shown the some cases the good results. Yes, some studies have come, Dr. Ratna, for the
Yeah,
regarding the use of
I
Dr.
think in a deep infiltrative, it's very difficult to fulgurate everything, and even you are in a, so even the role of the GNI channel, previously we used to give a danazol, now we don't use that.
Yes,
So all this medical, I think, definitely has a role in this, because that is the only thing where you can use when they have a, I think it is a stage 4 of the endometriosis, deep infiltrating, where you can take it out the bunch also, still the endometriosis remain like that, and it get
True.
Oh, thank you, ma'am. And now we have a question for Dr. Rajshree, ma'am.
Yes.
Hi, ma'am. Myself, Dr. Rajshree.
Okay.
I'm
Question of
gynecologist.
Rajshree to Rajshree.
Rajshree to
Yes.
Rajshree.
Now I'm 21 weeks already on metformin. Can I start MI and DCA now?
Yeah, you can start in that, because it is safe, they have said, and metformin is a category B drug. Even with that also, if you are under control of this metformin, then you can consult to the diabetologist also, and with that you can start in that. But depending upon your blood sugar levels also, because even there are patients, this MI has come now, but we used to control such patients with even with the metformin in that actually.
Correct. very clear, correctly mentioned. I'm speaking to this Dr. Rajshree, not to my Professor Rajshree. Huh? So, so Dr. Rajshree, see, there is no harm in taking of this myoinositol and decarboxyl. It's a kind of a group V of V vitamins. It is not
Yes.
going to harm you and your baby. So you can definitely take this and consult your diabetologist, the physician, and the gynec under whom you are concerned, that how your levels are fluctuating. If it's coming under control, in some patients easily we can shift from metformin to myo and decairo. Yeah, I hope Professor Rajeshri will be agree with me on this.
No, that is there because
Ha,
shifting is fluctuation depending on that.
ha.
Only if she has a brittle type of the diabetes where unstable sugars
True.
are there, then that shifting will be a more difficult in that. So she can go with this, slow transfer of this metformin to the myoinositol. Yes, any questions? I saw one question there.
Yes. From Dr. Komal, myoinositol come in the form of tablets or sachets.
Yes, Someshwar, tell now.
Both,
both, ma'am.
both.
In the both.
It is
Both
both.
it is.
They have. You
Uh-huh.
can take it in a.
It
that
comes
is
in both.
they
Just
say
so
that it comes in a drink form.
Yes, ma'am.
I mean,
You get the 2 grams in a sachet form and 550 mg in
but
of
people,
-1
patients
tablet.
are very happy in that.
Okay.
Someshwar.
Yes, ma'am.
Yeah, because they says na they don't feel like it. They don't feel that that is the medicine.
Yes. That's
so much, but ideally the dose should go minimum, Dr. Komal,
4
per day,
gram.
the 4 gram.
4 gram per day.
4 gram.
Don't
So
go for.
means I think their sachets what are available of Shield are plenty, very good results. Means so most of the patients are having no compliance or very good results.
Myoinositol is very important, because it regulates at the cellular level. So basically, you want a drug which is even going into that glucose uptake at the cellular level and signaling of the insulin. So I think that helps. Yes.
ma'am, I don't find any more questions in the comment box from the delegates. So if you allow, then we'll close this webinar.
Yes. Yes. Thank you
Yeah.
so much, Shwar. Thank you,
Uh,
Dr. Ritu, dear friend. Thank you, the dear friend, Dr. Prachi. Thank you, Shield, and wonderful audience for patient hearing. Thank you very much, and all the best to all. And sorry for joining late.
no, it's okay, ma'am.
It's
Yeah, even
okay. It's
though
okay.
even a tough time, you made it on the right time, actually.
Yes.
Yeah.
Yeah.
So with
Thank you,
this,
Rajashree ma'am, and thank you, Ritu Sanpani ma'am, for your excellent and valuable time giving for us and giving us a very good lecture. Thank you, ma'am, and many thanks from the Shield team as well.
Yes.
And I also thank all the delegates for participating in this webinar.
Yes. Thank you. Thank you,
thank
sir.
you. Thank you so much. With this, we will wind up. Bye bye. Good night.
Bye.
Bye,
Good
ma'am.
night.
Good night, ma'am.
Good night.
Take care.